Okay, to respect people's time, we may have a slow roll into getting started as people come over. As many of you know, Dr. Shenoy is an associate professor of hematology and oncology as well as pathology here at Northwestern. He also is the director of our kidney cancer research program. He, performs a care for all genitourinary oncology, but particularly I think of him a lot as one of our kidney cancer experts. He's going to present tonight on derivative survival analysis. And, if you want to see more after this presentation, he has a recent good publication in, I think, Cell Reports of Medicine, if I remember correctly. So thank you so much, Dr. Shenoy, for doing this tonight. Folks will be joining as you go on, but maybe get a slow roll and everyone will catch up. All right, Dr. Shenoy, I would say go for it, and we're going to record this, and we'll send out a message to people who missed a little bit of the front end of it.
All right. Okay. So thank you, Dr. Ross, and thank you for this invitation. So it's my first talk on this topic, and I'm hoping one of many. So there was a recent publication on this. I recently published this, as Dr. Ross mentioned, in Cell Reports Medicine. So give me 1 second here. All right. So nothing to disclose, right? And the source of information for this talk will be from peer-reviewed publications and mostly high-impact journals, FDA approval announcements, NCCN guidelines, and a few graphical representations of study designs from Euro Today, which is a urology news outlet. All right, objectives for this talk: derivative survival analyses. What is it? Why is it important? Examples of multiple GU Oncology trials, as Dr. Ross mentioned. I see GU Oncology patients here at Northwestern with an academic focus on kidney cancer. I also have a lab-based program, and this was a topic that was at the back of my mind for quite some time now, and I'm very glad that I could see this through. And then, finally, there'll be an overview of the methods as well. But that's a link to the paper, which was recently published. So, what is derivative survival analyses? Essentially, statistical analysis methods to derive the unpublished specific survival outcomes of remainder subgroups of a randomized controlled trial using the published data of the overall and favorable subgroup cohorts, without using individual patient data. Might be a big definition here, but the fundamental problem that this topic addresses is that often industry-sponsored randomized controlled trials do not release specific survival data for subgroups with inferior outcomes. I know many who are attending this talk here are very familiar with this problem, but there might be some who might not be, and so I'm going to go over this problem in a bit, over 10 to 15 minutes. So for those who are really familiar with it, please bear with me. So I'm going to go over a few examples over here. Okay. So Javelin Renal 101, for example, is a phase 3 large multi-center study, first-line clear cell renal cancer. Stratification based on functional status and geographical region. Patients are randomized to receive avelumab, which is an anti-PD-L1 immunotherapy, plus axitinib, which is a tyrosine kinase inhibitor, or sunitinib. Primary efficacy endpoints for PFS or OS in the PD-L1 positive tumors, and secondary endpoints for PFS and OS in the total population, right? So these were the data that were released, right? So patients with PD-L1 positive tumors, you can see a nice separation of curves here, and you have a hazard ratio of 0.61, right? And for the overall population, also there's a separation of curves, not as prominent as the PD-L1 positive tumors. The hazard ratio is 0.69, right? So the first thing you notice here is that, with the overall population, the patient sample size is, it's about 886. And over here, you have about 560 patients, right? So with the PD-L1 positive tumors. So you have close to 65% of the population that is represented by PD-L1 positive. And the 35% that are PD-L1 negative or unknown basically accounted for the hazard ratio changing from 0.61 to 0.69, right? So mathematically, when you think of it, you're thinking, all right, maybe somewhere in the upper 0.7s or 0.8s, and for that sample size. But that but the survival curves for that population was not disclosed. But they went on to seek and then obtain an FDA approval regardless of PD-L1 expression. Right? So this was in May of 2019, and it had made its way then into the NCCN guidelines again without any mention of the PD-L1. And once this happens, as many of us know, once there's a like an agnostic approval for certain agents, often in clinical practice, it is then not checked, right? So two common things happen. So either a PD-L1 is not checked upfront, or if it is checked, these are the data that people often go by. Even clubbing the PD-L1 negative, they are treated as per the data of the overall population because the specific data are not released. And that can be a problem, right? So when your intervention arm has toxicities that are substantially higher than the control arm, you're going to have to weigh the toxicity and the potential benefit for accurate clinical decision making. And so that's the issue. So that was one trial. And then in Checkmate 274, this was even more prominent. So this was a phase 3 randomized trial in adjuvant nivolumab versus placebo in high-risk muscle-invasive urothelial cancer. So patients were randomized after cystectomy to adjuvant nivolumab versus placebo. Primary endpoints were disease-free survival in the ITT population and in the tumor PD-L1 more than or equal to 1%, right? So kind of similar to the previous trial. And here you can see a bigger difference, right, in the curves. So you see the intention to treat population here, a hazard ratio of 0.7, right? And the total population here is about 709. And with a PD-L1 more than 1%, it's about 282 patients, right? So that's about 40%, around 40% of the patients, and the hazard ratio here for this population was 0.55. And then the specific survival curves for the PD-L1 negative one or unknown was not disclosed, but as you can imagine, it was sufficient to move the hazard ratio from 0.55 to 0.70 for the overall population. And interestingly, in a very busy forest plot, at the end of it, they did happen to disclose the PD-L1, less than 1% data, and the hazard ratio was 0.82, as kind of expected, and it kind of crossed the 95% confidence interval, crossed 1 for a fairly large sample size. Right? But then they too got a PD-L1 agnostic approval from the FDA and made its way into NCCN, again without consideration of PD-L1. And as a result, it is very common clinical practice not to test for PD-L1, or even if it is checked, you go by the overall population again, right? So that's the issue. And you might say that in those two trials, well, they were pre-specified, so they were perhaps not obligated to release those results, even if they can, etc. But then you also see this in the post-hoc setting, right? So, for example, in Checkmate 214, this is the first line, again, kidney cancer trial, large phase 3 randomized, patients randomized to Nivo plus EP, followed by Nivo versus sunitinib, right? So these are data from 5-year follow-up. It was released in 2022, and here you see overall survival for the overall intermediate and poor risk population, and the progression-free survival for the intermediate and poor risk population. And then you see the post-hoc analysis that was released only for the sarcomatoid subset, right? A huge difference here. But the sarcomatoid subset is about 15 to 20% of the patients. So a big difference. But the specific data for the non-sarcomatoid population is, again, not released. So you get the point. This one was kind of interesting. I thought Javelin Ladder 100. So this was maintenance avelumab after standard first-line chemotherapy in the metastatic setting, right? Avelumab, again, it's a anti-PD-L1 agent. So patients are randomized either to avelumab plus best supportive care or best supportive care alone, and the primary endpoint was OS. And so in the main publication, they released the data for the overall population and the PD-L1 positive population, and you can again see a difference, in the hazard ratios here. But in the supplement, buried in the supplement was this curve, for PD-L1 negative, where, I wonder if they were asked to release it, either the reviewers or the editors, but they released it. So you can barely any difference there for the PD-L1 negative population, right? They got a PD-L1 agnostic approval again, and again, it's common practice not to check for it. It's again in the NCCN guidelines without a PD-L1 consideration. So you get the point. And what complicates this matter is the lack of individual patient data availability, right? And so there's a substantial proportion of our pivotal randomized clinical trials that are ineligible for individual patient data sharing, and when you don't have that individual patient data, getting the data or derive for that specific subset becomes even more difficult, right? Wanted to highlight this one study which I thought was so important and so well done, and really credit investigators there and also the journal for publishing this. It was published in 2022. It was so this paper systematically evaluated data sharing of some pivotal RCTs of recently approved anti-cancer drugs, and what they found was that out of 304 trials which underpinned FDA approval of 115 new anti-cancer agents over the prior 10 years, only 45% were eligible for IPD sharing, right? And the most common reason for them to be deemed ineligible for individual patient data sharing was that the company said that the follow-up was still ongoing. So this was much after receiving, regulatory approvals. And this was really striking, right? Less than 10% of trials on nivolumab and pembrolizumab, which are our two most commonly used immunotherapy drugs, anti-PD-1 drugs, less than 10% of the trials were available for individual patient data sharing, right? So some drugs do worse than the others in terms of IPD sharing. Nivolumab and pembrolizumab being less than 10, nivolumab was 0. And some companies do worse than the others in terms of IPD sharing. You can see Merck here and BMS right here. Right. All right, so that is where derivative survival analysis comes in to help us get really accurate data for that remainder subset, so that when we see patients, we can present data that is specific to their biologically and clinically relevant subgroup. Okay, so this graphical there's a graphical abstract which is in the paper. So essentially, what it entails is reconstructing the published curves of the overall population and of the favorable subgroup that is published. So this is the really complicated part. But once this is done accurately, then deriving and constructing the data for the remainder cohort, right? So and then there are two methods: one to get the curve, and the second method to derive the hazard ratio and 95% confidence interval with the using a meta-analysis approach that I'll go over in a bit. So two methods. So the first method basically derives the curves when you have the curves of the overall population and the favorable subgroup population, right? And then simultaneously estimates the hazard ratio and 95% confidence interval using KM summary statistics. Okay. So this was one of the examples, in the paper. So Checkmate 7274, for example, you see this right here, right? So this is for the overall population, and this is the PD-L1 population. And with the curves, getting these to really resemble them, that is fairly complicated, because you have to estimate for each time interval, what were the number of events, the number of patients censored, and the survival probability, and get these estimations, really accurate as much as possible, and then ensuring that the hazard ratio and 95% confidence interval that you calculate with those numbers, and I'll show you a snip sheet of the calculation spreadsheet, a snip of the calculation spreadsheet, but ensuring that calculated HR and 95% CI very closely matches the published HR and 95% confidence interval, right? So once you have this, then you're good to go for the next step. So, but getting these curves to exactly match can be fairly cumbersome, and the model that I used here for this method was the Tierney et al. Model. So, Tierney et al. It's a seminal meta-analysis paper that was published in this journal called Trials back in 2007. Has been cited thousands of times, and so this is a snip of the calculation spreadsheet, and so what you see here is that this is for the intervention arm, this is for the control arm, and you have to do it such that the survival probability and and the number of events and the number censored for each time interval very closely matches what is published. So I use a high resolution, then use rulers, etc. And then the calculations basically involve estimating the effective number at risk, and the expected number of events overall, and then observed minus expected, data that you organize for a log rank test, and then you get the natural logarithm of the hazard ratio with a sum of the observed minus expected divided by the sum of the variance over here, and that's what you kind of get over here. So and then from these two you estimate the HR and the 95% confidence interval, and then you make sure that that is very closely matching what is published. Okay? And often when the baseline characteristics are well matched, there will not be much of a difference between the HR 95% CI derived with this method and what is published. Okay. And so as you see over here, these numbers that were calculated very closely matched the published ones, and then you have confidence that the numbers over here are fairly accurate. And once you do this for the overall population, and then for the PD-L1 positive population, you can then derive the numbers for the PD-L1 negative population by basically subtracting the number of events, subtracting the number of censored patients, and the number at risk. And so you get all the numbers for the PD-L1 negative population, and then you basically derive the curve for that. All right, so this is how it looks. So PD-L1, so this is for the overall, this is for the PD-L1 positive, and this for the PD-L1 negative. And once you have a curve like this, right, and then you think to yourself, you discuss with the patient, or you're considering, Edin and nivolumab for a patient like this, where there's really no long-term difference in progression-free survival, this would weigh strongly in your decision making, right? If it's a PD-L1 negative, particularly in settings where, say, for example, like you're borderline, you're on the fence about chemotherapy. Maybe hearing is slightly impaired, or there's a mild renal dysfunction, and so the decision on chemotherapy is borderline, and this might really sway you one way or the other. Getting these curves, right? And what's interesting is the calculated HR 95% CI here derived with this exactly matches what they had released in in their forest plot. But having just a HR and 95% CI does not give you the full information, right? So what's really important in decision making is the absolute risk reduction, right? So that is the most important factor in decision making. So when you see your patients, you should be able to tell them, if you don't do it, here is where you are. If you do it, here is where you are. And at different time points, here is the absolute risk reduction. And then these are the side effects that you weigh it against, right? So, so the derivative survival analysis enables that for these patients. Until the individual patient data eventually get released by the companies, perhaps a decade later. So, then did this for 3 other trials. So this is for JAP. You might ask, how accurate do you think this is? I mean, mathematically, with this method, if these 2 curves are accurate, there is a very high degree of accuracy with this. And with this trial, I could even demonstrate that. So Javelin Bladder 100, like I'd mentioned, they had released the data for the PD-L1 negative subset in the supplement, as you can see over here with the derived survival analysis for the overall survival for the PD-L1 negative population in that study very closely matches what they released for a PD-L1 negative. This one included even the unknown ones, so had a slightly higher population, but still, very closely matches that. So again, this was also done for Javelin Renal 101, which is avelumab plus axitinib versus sunitinib in RCC. Again, you see the same thing, right? PL1 positive, you have a nice separation of curves. Negative or unknown, not so much, right? Okay. So and yeah, so these curves, really matched the ones over here. One of the things is within a time period, it's difficult to, like if you have numbers for like this time point, you're not going to get a curve like that. With this method, it just goes just like that, but it does not influence the final calculations. Your calculations will still be, really accurate. You see the HR 95% CI. So you get the point. So essentially, the critical cumbersome part here is ensuring that these two curves that you reconstruct are, really closely resemble what's published, and the numbers closely resemble what's published. And whatever numbers are released, like the median PFS or PFS at a certain time point, making sure that you hit them in your reconstructed curves. Once you do that, the derived curves are, will be accurate. Okay. And this is for the sarcomatoid and non-sarcomatoid RCC. Again, for the overall, the HR is 0.73. Sarcomatoid, here it's 0.50, and for the non-sarcomatoid, it's 0.79. And remember that this is the non-sarcomatoid for both intermediate and poor risk population. And we know that the NeoAP is much better than sunitinib in the poor risk, more so than in intermediate risk. So looking at the 95% confidence interval here, I think it's safe to say that very likely just the intermediate non-sarcomatoid for that patient population, there would not be a significant difference. All right, so method 2. So that is so that was method 1, which gives you the curves and also helps estimate the HR 95% CI. It's kind of cumbersome. But if you want a quick analysis of just the HR and 95% CI for the remainder patient population, this method 2 can be used. And essentially, this is what it is. It's you use this thing called an intra-trial fixed effect meta-analysis with inverse variance weighting. So it was basically a mathematical observation that I had made last year, which forms the basis of this method, in that in that the subgroup HR and 95% CI, when you do a meta-analysis within the trial, they exactly add up to that of the overall population, right? So for example, so I'm just using this as an example to convey this method. So this is from Checkmate 9ER, Nivo plus Cabo versus sunitinib. So they released the data for sarcomatoid and non-sarcomatoid and for the overall, right? So now, with a summative analysis of this A plus B with a fixed effect meta-analysis, so this is the HR and 95% CI of the non-sarcomatoid right here. This is the sarcomatoid one, and when you do a fixed effect meta-analysis, it exactly adds up to this, right? Now, regardless of the degree of heterogeneity, so this when you do a meta-analysis, it's we usually use a random effect to account for heterogeneity of effect between the populations, and there's a correction factor that we use in the random effect. But basically, what I found is that for the purposes of this calculation, doing a fixed effect gives us the accurate results, and not random effect, regardless of the degree of heterogeneity. So once that mathematical basis was established, it was then it then becomes kind of it's like a backward calculation of HR 95% CI of the B if A and A plus B are released, right? So basically, now if you assume that B, HR and 95% CI were not released, and only these two are released, so essentially these are the steps involved. So these are detailed step by step. Both these methods are detailed step by step in the star method section of the paper. So you first obtain natural logarithms of those two populations, and the reason for doing that is because the logarithm of the hazard ratio closely approximates a normal distribution. So that's the first step, so obtaining natural logarithms, and then you calculate the standard error, variance, and weight for both those populations. And once you derive that for both the populations, you can calculate that for the p with this. So the weight and so the weight of this p population will be equal to the weight of this minus weight of that. Okay, weight of the overall minus weight of that, and the effect times weight will be equal to the effect times weight of this population minus effect times weight of that. And once you get that, you can then derive the effect, which is basically the natural logarithm of the HR, this divided by this, and then you can calculate, the variance, which is 1 by weight, and, the standard error to the square root of variance, and then you get basically the HR of 95% CI, and then you see this number 0.6, 0.48, 0.73, and you compare it to what is published. So it gives you an accuracy of within 100th of a decimal. Okay, so I'm working on, instead of having to go through all the steps, I'm working on like an online, like a web tool, where clinicians can just go in and type the numbers of HR 95% CI for the overall population that's released, and for the favorable subgroup, and then should give the results for the remainder cohort, right away. So just developing, like a web tool for that, right? So using that same method, so another example for deriving the non-sarcomatoid RCC in Checkmate 214, which was not released using method 2, going over the same methods, you basically get a HR 95% CI with those methods of this number. And then you can cross-check that it is accurate by using that fixed effect meta-analysis and making sure that the sarcomatoid plus non-sarcomatoid exactly equals the overall population. So that's essentially, method 2. And, so there is a way of approximating the absolute difference once you get a hazard ratio, at a particular time point, if you know the percentage survival probability of the control arm. So this is kind of the formula with that. So just as an example, if you have a hazard ratio of like 0.8 with an estimated 3-year survival of 60% for the control arm patients, right? You can calculate the absolute improvement with this formula. And so that would basically mean a 6.5% difference from 60 to 66.5% at 3 years. So getting that then enables you to kind of have, let the patients know what the absolute risk reduction is, which is a metric that needs to be used in clinical decision making, and to help patients really understand what they're signing up for. So that's so applications of derivative survival analysis, in day-to-day clinical practice decision making, this can be really useful, and I'm really hoping that with this paper and there's more awareness, and that we start using and obtaining these biomarkers consistently, PDL1, etc., and start thinking about biologically and clinically relevant subgroups, and not club all patients into the overall population, right? So it's almost like there was so much work done in the preclinical setting to develop this as a biomarker. It almost feels like a reversal of precision medicine in the clinical setting, where we don't use that so much, so I'm hoping that we can do that consistently to identify these, relevant subgroups. This is something that can be used by regulatory agencies, particularly international regulatory agencies, to determine if their approvals need to be tailored to specific subsets, right? Because, for example, the Checkmate 274 data, right? You have amazing results with the PDL1 positive population, but really cold, not much, with a PDL1 negative. So for so for countries that are economically backward, would they consider approving it for certain subsets, using this? So that's a possibility. I think it should be strongly considered here as well. And regardless of regulatory approvals, my real hope is that clinicians can really use this in decision making. That can be applied, across subspecialties, not just limited to oncology trials. So has a huge, application, and hopefully compel the industry to, release subgroup specific data once they recognize that this can now be easily derived for all subgroups using this method. So acknowledgements. Although this was a single author paper, obviously, a lot of support goes into allowing this to happen. So the school, the hospital, the cancer center, American Cancer Society, and the Hecht Memorial Foundation, and my lab members too were amazing. So, all right. So thank you, and happy to take questions.
I'm contemplating how much I'll use this in my own practice, but I wondered if you had spoken to any of the and I don't know what the avenue is to speak to any of the regulatory agencies like the FDA about at least sort of having a movement towards compelling the release of the subset analysis data
Yep.
and kind of it'd be interesting. I don't know how one goes about instigating change in this way.
Yeah.
And there's a lot to be said about release of sort of the I don't want to say necessarily primary data, but the release
Yeah.
of a lot of the
Individual patient
almost
data.
primary data from these trials, because
Mhm.
it will help us individualize patient care, whether it's derivative or direct. So
Yeah.
I don't know how one goes about doing that.
Yeah, that's a great point, and I definitely think that academic oncology as a community can do a lot more, right? Because when patients enroll in these trials, right? Yes, they're all they're doing it for themselves, but most often there's also an altruism element, right? That they want to that they want to have options for other patients like them, etc. So there is that altruism element, and when you see such a large portion of trials that are not eligible for data sharing, um, it's a disservice to that altruism, right? And, when you use the data to get a regulatory approval, I would think that the data is mature enough to be released, to the academic community, and not sharing that with the reason being, just collecting follow-up information. I don't think is a strong enough rationale, right? And I think this dialogue needs to be had more within the academic oncology community and hopefully with regulatory agencies, etc. But until that happens, I'm not going to hold my breath on that. This can be used, right? So.
Yeah, I think a couple of things. One, sometimes some of the governmental agencies, when the government runs trials or NCI or others, will release some of the
Yeah.
data. I can think about like a trials that I've on the prostate cancer side that we've been able to get data from pretty freely.
Yep.
The other thing I would say is like, it's another thought about how do you modulate behavior, because I do actually like the agnostic approvals in some sense. I mean, I don't practice medical oncology, but it gives you flexibility in your practice for cases where something is directing you towards that more
Yep.
broad, approval. And so I don't think that's the problem. I think it's more what you were saying, which is like, how do you actually provide a clear message for practitioners and give point estimates for if the patient is not responding the way you would have predicted by the
Yep.
trial, change therapies. And that's also harder to think about. But anyways, it's very,
Yeah.
very fascinating.
I think that's an excellent point, right? Like having broader, agnostic approvals gives you more options and, makes them readily available in case you don't have other options, etc. So that's an excellent point. But I think that, at least in the approval announcements, you think that they can be, something saying that the data was strong in this particular subset, but we're still approving over here. Something that makes, or even in the NCCN guidelines, something that makes clinicians think along those lines, right? Because if nothing is mentioned along those lines, even in say the NCCN guidelines, then it becomes really common practice to kind of ignore that aspect, right? So yeah, a lot of dialogue to be had, I think, to consider the subset approach.
Last thing I'll say, and then if there's any other questions, please jump in. It'd be interesting if, I unfortunately I don't think Dr. Hussain is on tonight, but it'd be interesting if you have not already to kind of share your thoughts in depth with her, as kind of a more of a leader in this area. In general, like, just a pillar of oncology, she might have more access to larger, groups. Have you talked to her about this, and what's her
Not
thought?
not yet, Dr. Ross. This just got published, I think, couple of weeks ago. I haven't met her yet, but I will in the short. I mean, I hope she's seen the paper, but I plan to discuss it, with her. But yeah, hopefully there can be, change in the in the right direction, or even if the other other thing that can happen is if reviewers start asking for it in these very prominent journals, reviewers and editors, they could compel the industry to release that data and not get away with just either releasing only the HR in a very busy forest plot or etc. Right? So that is something else that can happen. And I think if it's there in the journals, then the clinicians would really see it, and it's easier for them to incorporate that in their practice.
I totally agree. Any other questions for Dr. Shenoy? Okay, well, really, thank you so much for having this talk. The talk will be recorded. If anyone wants to listen to it, it'll be up on our website, and we may distribute it once it gets posted. Thanks again, Niraj. Really appreciate you being here.
Thank you, Dr. Ross. Thanks so much. Yeah, thanks everyone.